My name is Rashmi Halkar Singh, and I'm the Deputy Editor of Headache. It's my pleasure today to be joined by Dr. Ashley Polk, who's one of the authors of a recent publication entitled A Meta-Analytic Review of Acceptance-Based Interventions for Migraine. So welcome, Dr. Polk. It's a pleasure to have you join us today.
Thank you so much for having me. I'm excited to be here with you.
So this is a really interesting manuscript, and I have a few questions I want to ask you about it. You began your paper by sharing with us about the fear avoidance model and kind of use that framework to share about your study. So I was wondering if you could just talk about the fear avoidance model for a minute and how that relates to migraine and your study.
Sure. So the fear avoidance model, for short, we tend to call it the FAM. So I'll use that just to make things a little bit briefer. But the fear avoidance model of pain was actually originally developed to explain the experience of folks who have musculoskeletal pain. And so essentially this model says that when folks experience injury of some variety, they of course have a pain experience in response to that injury. And for folks who respond in a really adaptive way to their pain, they're involved in recovery, for instance, or physical therapy. Those folks, they don't tend to have very much fear of pain or fear of re-injury. And so they're confronting things that they need to do in order to get better and to heal appropriately. On the other hand, what we tend to see is that sometimes when folks have this pain experience, they engage in what we call pain catastrophizing. So this is essentially dwelling on or worrying about the worst possible outcomes related to pain. And when folks have pain catastrophizing thoughts, this increases the amount of fear that they have about the pain experience, and they're worried essentially that they will re-injure themselves. So they become avoidant and almost hypervigilant around their behavior, trying to not exacerbate the pain experience. And while that makes logical sense, we see that oftentimes for folks, this leads to physical deconditioning, increased disability, depression, for instance. So that's the original model. It's been more recently applied to headache because we know that folks who have headache, whether that's tension type headache or migraine, they can also respond to that head pain with pain catastrophizing. Thoughts like will never go away. I can't handle this. I can't do the things that I need to when I have head pain. And so what we see is that when folks with migraine pain catastrophize, they subsequently avoid things that are important to them, work, family obligations, social obligations. And not only does their pain become exacerbated, but their world gets much smaller because they're not involved in things that are important to them. So that's really how the fear avoidance model applies to migraine. And like you said, it was really the framework for thinking about the development of this paper.
Thought that was a very interesting model to think about pain. I often explain pain as a very individualized experience to my patients and why their pain score might be different from someone else's pain score, but it's very valid. And I
Yes.
think I'll include this in my conversations with my patients too. So, can you tell me about your study? What did you do? What did you find?
Sure. So essentially, I wanted to look at the efficacy of what we umbrella termed acceptance-based interventions for migraine. So this included acceptance and commitment therapy, or ACT, and mindfulness-based interventions that are structured. So mindfulness-based stress reduction, or MBSR, and mindfulness-based cognitive therapy, or MBCT. And so I was really interested in how efficacious are these interventions for migraine, but also how efficacious are they in improving what I would call process-based outcome variables, so primarily disability. We also wanted to look at how these interventions impacted attack frequency and folks' consumption of rescue medications for migraine. So essentially what we found was that acceptance-based interventions broadly had small to medium impact on improving disability for folks with migraine. And this was true for people who have episodic migraine and chronic migraine. Then we looked at these treatments more individually. And so mindfulness-based interventions, particularly mindfulness-based stress reduction, yielded medium improvement on disability for folks with migraine compared to control. But surprisingly, ACT, which there were only a few ACT studies that we included, ACT initially did not yield significant improvements in disability for folks with episodic migraine, but did for folks with chronic migraine. And then otherwise, in terms of these more what I would call traditional headache variables like attack frequency, medication use, we didn't see any significant improvement there. But we weren't necessarily concerned about that because these types of interventions that we call third wave behavioral interventions, they really focus on improving process-based or quality of life types of variables like disability, and they're less focused on symptom reduction. And so we weren't expecting necessarily that headache attack frequency would decrease, although that would have been a nice side effect, so to speak.
So based on your results, how does all of this fit into our management of migraine? Has this impacted your practice at all?
Absolutely. So I think, there's a lot of literature out there about behavioral interventions for migraine, whether that's something like cognitive behavioral therapy or the learning to cope with triggers framework. And so it was really my hope that understanding the efficacy of these interventions would essentially add to the list of possible treatments or interventions that we can offer to our patients. My hope is that these things can be offered more widely, whether it's alone or in combination with medication management. And in terms of my practice individually, I do see folks that have headache and migraine. And so I think for me, it's opened up some additional options that I can provide my patients, which is really nice because I think it's important to tailor intervention options and give folks a choice in how they'd like to manage their conditions. And so I think this was really another way to increase those menu offerings, so to speak.
Absolutely. I love that, we have additional tools in our toolkit when it comes to migraine management. But sometimes these specific types of tools are not readily available just because we don't always have easy access to psychologists who offer them. In those situations, what do you think clinicians should do? Do you have any thoughts on that?
Yes, this is actually something that's really important for me. I did my graduate training in Mississippi, and there were lots of folks that had understandable barriers to mental health care. And so while there's no specific, I would say, app like ACT for headache right now, I work for the VA, and so I'm aware of numerous applications that are being developed in the chronic pain world broadly, but also within the headache and migraine world more specifically that will help folks self-manage and learn some of these skills on their own. Those things certainly are in development, and so I can't offer more specific guidance right now, but I know that's something that we're all really thinking about is how do we increase access to folks so that people can self-manage without the need to access a mental health provider, for instance.
Wonderful. Do you have any additional thoughts you want to share with us?
I really thank you for having me, and I hope that this is a paper that folks are excited about. Again, I think there's a lot more work that we can do in really understanding the efficacy of these types of interventions, and certainly there are suggestions for future studies outlined in the paper, but I think this is a really promising avenue, and I hope that it benefits our patients as much as it benefits us as providers.
Thank you so much for taking the time to speak with me today.
Thank you.